Good afternoon, everyone. My name is Dwayne Schultes. I'm the Managing Director of Vital Transformation, and I'd like to welcome you to this final webinar in partnership with FPIA discussing COVID-19's impact on cancer research and delivery. The webinar today is called Looking Past the Pandemic, Cancer Care for 2022 and Beyond. We're interested in looking at things, at how they're going to move and progress after we get past the pandemic. So with that, we have a fantastic panel today to work with you. And given the current reductions in GDP due to lockdowns, what will be the long-term economic impacts of COVID-19 pandemic on our EU health infrastructure? How do we ensure a post-COVID-19 Europe continues to support healthcare innovation? And what are the potential barriers post-pandemic on cancer treatments? Will there be a push to alter the European Commission's priority to focus on cancer after the pandemic? And what changes, if any, should be made in the EU given what's happened with COVID-19 related to cancer treatment? So with that, I'd like to introduce the panel for you, starting off with MEP Peter Liese, who's joined us from the European Parliament. Hello, MEP Liese. How are you, sir?
Fine.
Thank you very much. From the OECD, we have Catherine DiBianesi, who's a health policy analyst. Kate, thank you very much for your time.
Hi, everyone. Thank you for having me.
From the European Oncology Nurses Society, the recently elected president, Johan de Munter, the very well-coiffed Johan de Munter. Hello, Johan. How are you, sir?
Good afternoon, everyone. Welcome. Thank you very much, Dwayne.
Thank you. From the VFA, Han Stoidel, the president. Han, thank you very much for joining us.
You're more than welcome.
And Evert Jan van Lent from MEDEV and the AOK. Evert Jan, thank you very much, sir. How are you?
I'm fine. Thank you for inviting me.
Thank you, sir. So the first question I have, I'd like to direct this to MEP Liese. MEP Liese, cancer was a top priority in the new commission, and it's certainly been something that you're focused on in the Parliament. You've recently set up a special committee on cancer, and this was when COVID-19 started to emerge. Have your original plans for cancer changed since the outbreak of the pandemic?
Unfortunately, yes. So when we were just about to establish the committee, the lockdown happened, and we are working hard in the European Parliament. We have video conferences. We have also plenary debates, as you may have seen last week, but we are limited. And that's why the special committee is not yet established. I regret this very much. So there will be a kind of postponement, but I think we shouldn't give up. Cancer is still a very important topic, and many people die, and we need to fight cancer. And I think even when the crisis have changed priorities, it should be clear that the priority health should stay. And we have learned in this crisis that health is much more important. Also, European cooperation in health is much more important. And I want to give you one example that this is already obvious in the European Parliament. When I asked for an initiative report, so an initiative of the Parliament, a resolution which asked the Commission to act on the shortage of medicine in January, my colleagues from the other political groups said, no, we don't have time for this. The Green Deal is so important, we have no time for these health issues. And now this report on the shortage of medicine is the only initiative report, the only non-legislative report that the ENVI committee works on. So priorities have changed for the better. I don't think that environment is not important. We need to continue the Green Deal, but health is at least as important as environment. And I think that's why after these problems in the lockdown, the cancer priority will come bigger after the crisis than it was already before.
And is there a lot of collaboration between the Parliament and the cancer planning of the European Commission? Is there coordination there?
Definitely it is. We started already to coordinate. You know that the big event to start a public consultation with Ursula von der Leyen and many experts on cancer, it was in the European Parliament. That was a very important signal that the Commission wants to work with that. It has been a bit difficult during the last weeks because, first of all, as I mentioned, this committee is not yet established. And second, of course, Stella Kyriakides, Ursula von der Leyen, and many others are really in the pandemic on COVID-19. So we have to work hard to really fight this pandemic. But I'm 100% sure that when we have settled things a little bit better, that the priority for health and also the cooperation between the Commission and the Parliament will come bigger than it was before the lockdown.
Thank you very much. I'd like to turn to the OECD. Kate, the OECD has been discussing concerns about the lack of healthcare investment to keep pace with demographic evolution. Obviously, according to current statistics, by 2055, 20% of the population is going to be 80 years or older in Europe. What will be the impact on cancer treatment post-COVID, given the fact that we were already underfunding? What's going to happen now?
Great. Thank you so much, Dwayne, and thank you to FPA for hosting the forum today and inviting the OECD to participate. And also thanks to the other panelists for being here. So I'm happy to talk a bit about some of the initial findings of OECD countries on the secondary impacts of COVID-19, including those on cancer. Even though things are still evolving quite rapidly, we're already starting to see the economic impacts of the pandemic and beginning to anticipate the impact of the pandemic on health access and outcomes. Initial modeling by the OECD suggests that GDP could potentially be reduced by 20 to 25% in many major advanced economies due to the pandemic. And there's no doubt, I think, that this will have an impact on healthcare budgets. At the same time, investments in health, as you stated, have been slowing. The OECD spending on healthcare grew by an average of about 2% in 2017, which was a decrease from over 3% growth observed in the previous 2 years. And that is, of course, at much lower levels than rates experienced before the financial crisis. And again, this is combined with demographic trends where countries have older populations with more ongoing health conditions and more complex healthcare needs. So one of the major worries of COVID-19, of course, aside from the detrimental impact of the virus itself, are some of these secondary indirect impacts that it's going to have. So a number of countries have scaled back delivery of non-COVID related health services in an effort to increase hospital capacity. For example, in Australia, all non-urgent elective surgeries were canceled during the peak of the crisis to free up space in hospitals. We've seen similar policies in the United States, Portugal, Chile. In Germany, while hospitals are returning to normal activity, they're asked to reserve between 20 to 30% of ICU space for COVID-19 patients. And beyond hospital care, a number of countries have postponed care in other settings as countries implemented policies to reduce non-essential medical care, including access to ambulatory care, routine vaccinations, laboratory testing, physical therapy, cancer screening, and other routine care. And this is having an impact. So research from the UK found a over 75% decrease in urgent referrals from primary care for people with suspected cancers, and a 60% decrease in chemotherapy appointments for cancer patients. But so we're seeing that on the supply side, health systems are limiting care, but on the demand side, we're also seeing similar changes where people are not seeking care for various reasons, whether it's due to confinement measures, fear of infections, or worries about burdening the healthcare system. So a number of countries have seen significant reductions in the use of outpatient services. A study from the US found that the number of visits to ambulatory practices decreased by nearly 60% and has remained low. And while telehealth has increased, it has only partially offset some of the drop in in-person visits. We see similar findings in France, where using the online medical appointment scheduling service, Doctolib, this service recorded a decrease of visits to general practitioners by almost half, and a reduction in specialist care appointments by over 70% during the crisis. Similar to the US, France found that only a low proportion of people with ongoing health conditions are using teleconsultation for follow-up care since the beginning of the confinement period. Another big factor I think that we're going to see is lost income caused by COVID-19 is going to have a significant detrimental effect on people living with existing health conditions. As people's incomes are affected, this could create a significant barrier for accessing care, particularly in countries where cost sharing from patients is common. While non-COVID related hospitalizations and appointments may be reduced during the acute phase of the pandemic, we've seen in previous situations that infectious disease outbreaks have shown that in the period following, there's a surge in needed care for countries as they transition back to normal activity. An example from countries that were affected by the SARS outbreak found that admissions related to diabetes increased dramatically following the acute phase of the crisis. And now we're seeing from the UK that cancer deaths might increase as much as 20% in the year following the crisis due to issues of delayed diagnosis and treatment. So what will the impact be? I think that we can expect to see a surge in care needs as confinement policies are lifted, and that countries are going to need to be prepared to scale up for those conditions that have not been treated in a similar way that they've had to scale up to respond to COVID-19. Thank you.
Thanks, Kate. Now, that modeling that you mentioned where you saw the 25% increase, do you think that would hold true for most of Europe, or is that just going to be specific to some areas of France, et cetera?
Which?
Well, you said there was a 25% increase that occurred after when things were opened up again.
Yes. Yeah, I think that many countries have seen significant delays in people seeking care or accessing care for various reasons, both on the demand side and the supply side. And I think that countries are going to see big unmet need in the months following the crisis.
And of course, that's going to then impact other budgets that have already been allocated as well. So there's going to be an even greater impact.
Sure, yeah.
Well, thank you. So that's sort of warm, happy news there from the OECD. Thank you very much, Kate. Johan, from your perspective, you are at the coalface, as it were. You're working directly with the patients, with your oncology nurses. Obviously, there's been an enormous stretching and pushing to the capacity as much as we could in Europe, given the pandemic. How are oncology nurses adapting to the fact that so many of these treatments have been postponed, and what do you think should happen?
Thank you, Dwayne, and thank you, EFPI, to having us and EONS here around the table. I think the COVID-19 crisis has definitely confronted cancer nurses with extra challenges in cancer care and the care they provide for people affected by cancer. And I think many cancer nurses are being transferred to assist overstretched nursing teams and COVID-19 wards, while other cancer nurses have to care for and support cancer patients in already existing challenging circumstances, which are now extra fueled by the COVID-19 crisis. For example, we have to work more hours, we have more stress, we are afraid to reinfect patients, we are lack of personal and protective equipments, because we have to rotate teams and we have to work with minimal resources, because by the COVID-19 crisis, we have like very, very much logistic problems also in the hospitals, and to provide the proper material to care for our patients. But I think also the current challenges during this COVID-19 crisis are also related to the under-recognition and under-investment in cancer nursing by policymakers about decades, and to understand and what should be the next steps. We know what these challenges are, and we know that barriers lack of access to treatments are well documented, but another range of crucial challenges that prevent access to safe and quality cancer care are under-recognized across Europe. For example, a lack of access to cancer nursing education and specialist qualifications for cancer nurses. And we know that evidence tells us that the availability of highly educated nurses is preventing hospital deaths. So we should invest in education and proper education for cancer nurses across Europe. We already know the existing workforce shortages, and specific in cancer nurses shortages, and therefore we should invest now and in the future about this nursing workforce, because like Catherine said, all the postponements in the cancer treatments and prevention and survivorship, this will create a second wave of healthcare use, and there we need all healthcare professionals and cancer nurses to cope with it. But also in the future, we had already access to poor safety equipment. For example, when we are administrating chemotherapy, we use this same personal protective equipments, and now we have, with the shortages and the use it for COVID-19, these shortages are increasing, and the working conditions compromising patient and occupational safety for cancer nurses. So I think, and it's already fantastic to see that much support from EU citizens for nurses across Europe, but I think policymaking community need to understand this, and that it should be recognized and invest in current and future multi-professional cancer care, inclusive in cancer nursing. And as largest group of healthcare professionals, we should also be invited to participate, especially in social and economic reconstruction of COVID-19, because cancer nurses all over, they are in the community, in the hospital, in survivorship care, in end-of-life care. We educate like healthcare professionals. And for example, we have a good strength here, because like we care for people that already are immune compromised, for example, and we teach them and educate people about infection prevention. And this is very handy at this point. So we are also kind of experts in preventing this, and we can use this at this moment. So people need to understand this. We have a great value in healthcare at this moment, and also on other times. And it's only in this way we can address all dimensions of cancer care due all circumstances and future challenges, and deliver safe and quality cancer care for people affected by cancer across Europe, I think.
Thank you, Johan. Very much appreciate your comments. Evert Jan, you're on the payer side. Obviously, you've just had a couple, shall we say, cold water, some cold water poured on you with regards to budget impact. What do you think is going to happen with the current outlook, given what you've just heard from both the delivery standpoint and the OECD standpoint about budgetary impact? How do you think this is going to impact your budgets to be able to continue to spend on cancer?
Yeah, thank you, Joanne. Basically, we are also calculating, of course, our financial situation, and I can confirm that the impact of COVID-19 will be enormous. So we have two different issues. The first issue is the revenues. We will see that due to the recession, we will have less revenues, and this applies as well to the contribution financed health systems, as also to the tax finance systems. And it will take several years until we reach again the level of 2019, we are afraid. So the revenues are associated with the level of income. So if income is low and if there is a lot of unemployment, we will have less revenues. Or we have to increase our contribution rates and taxes. And we are in Germany already discussing about the needed increase of contribution rates if the government doesn't pay for all the costs, for all additional costs we are making. But both things, increase of contribution rates and increase of taxes, is of course a hard thing to do during a recession. That is the revenue side. On the other side, we have the expenditures. As far as we had some reserves, as we had in Germany, some billion euros reserves, they are already crunched. We used it already for this year for the first wave of the pandemic, and therefore there are no reserves anymore. And on the medium term, I expect that we will have additional money for protective personal equipment, for health professionals, in inpatient care, outpatient care, in nursing homes, and so on, because this was one of the problems we found out in the first wave. So we must be prepared the next time. There will be new discussions on how we ensure the availability of hospital beds and intensive care beds and ventilators in the future, if there comes a second wave or a next pandemic. This was also one of the critical points. And this costs, of course, also money. And in the end, we are discussing, when we are talking about medicines, on stockpiling, we are talking about shortening the supply chain, meaning that we will want to shift production more to the EU, back to the EU, and this all will be associated with additional costs. So we will have an enormous budget impact, and we will see how we have to deal with that. I don't think that this will lead to a reduction of spending in cancer care. The question will more be, will the growth of spending in cancer care be the same as in the last few years? And in the last few years, we saw a considerable growth of cancer care spending. And I'm sure that all health systems will try to avoid and do what they can that all patients have access to effective therapies also for cancer care. And I think some of the consequences for us are that we should try to find out how can we be as effective as possible and as efficient as possible in cancer care. And I think this might lead to a further development of expert centers, that we have expert center for cancers who can guarantee that there is an appropriate use of expensive therapies using scarce financial resources. Because now we are sometimes afraid that patients get very expensive therapies who do not really take profit, not really are helped with this. And the other thing was also mentioned already, this is prevention. Prevention is, from my point of view, a very effective intervention. And this will be part of Commission strategy, I think. And I think we should do as much as we can to reduce the growing number of cancer patients in the future to maintain sustainability of our health systems. That's it.
Thank you, Jan. Of course, the problem with prevention is we've just shut off prevention essentially for 6 months dealing with the pandemic. So there's going to be a wave, one would assume. Han, I'd like to come to you now. Again, you're dealing with this. You're hearing a lot of bad news from an industry perspective. How do you think we're going to take this going forward?
What do you mean exactly by this? Cancer as a...
Yes. I mean, cancer has been one of the priorities of the presidency. Cancer's been announced as the decade against cancer. How do you think this pandemic is going to impact that?
Well, first of all, short term, the impact will, of course, be major, simply because of the fact that so many will have to deal with COVID-19 still, but also the effects of COVID-19 on healthcare systems, but also, of course, on the way we are living together. So that's going to still consume quite some of our time. On the other hand, the conviction that we should do as much as we can against cancer has not left us. I mean, if it's taught us anything in the past months, it is that health is probably even more important to all of us individually than we thought before. It has shown us how vulnerable we can be if we're not being protected in the way we should be. So if you look at the incidence prevalence of COVID-19 and compare them with cancer, I mean, the numbers are still stunning. If I take Germany, and I am aware that probably Germany has suffered less from COVID-19 than many other countries in Europe or in the rest of the world. If you look at the prevalence or incidence of COVID-19, it's still less than 1%. Whereas if you compare it to cancer, 50% of all citizens have the chance of getting to fight cancer once or even more than once in their lives. And it's still a mortality rate in the end of some 25% of people who have to fight cancer. So in terms of these numbers, it's still immense what we can improve and what we think we should improve. And I don't think there's any politician or any governmental officer who now thinks differently about this treatment and the necessity to deal with cancer. If you look at the industry side, we have just as a VFA published a couple of weeks ago an overview of all our members working on treatments against cancer and many other diseases with the outlook until 2023. We are currently investigating 200 new indications, either new molecules or new indications for existing molecules against cancer to come to the European market with a marketing authorization until 2023. So that's really immense what we are doing. It's affecting 40 different types of cancer, and this enormous flow of research and development is just going to continue. These resources have been allocated. So short term, between now and 23, from the industry, there's nothing to be expected in terms of changing their strategies. After 23, it may be a bit different because that's, of course, related to the planning that's taking place now. But we continue to be very positive that we can really make a difference here. If you look back the past 5 years, mortality for men and women in the European Union has gone down to cancer, mortality to cancer, between 4 and 5%. That is immense. And if you compare the amount of efforts in terms of cancer research and development now and 5 years ago, this is also already very different in terms of its magnitude. So our perspectives currently are extremely strong to take cancer casualties down further.
Thank you, Han. A lot of good points there. I'd like to turn to some of the questions we've had from the audience. And again, we've had quite a few come in here. Please feel free to submit them. Maddie Apro from ECHO, European Cancer Organization, has pointed out that Catherine has made an important presentation from the OECD that highlights we have not performed well in communication and organization. As suggested in the previous webinars, we have to learn and prepare for a better response. MEP Lisa, I'd like to come to you. How do you think we could have done the response better from a perspective of organization? What do we need to do next time? God help us if there is another pandemic. What do you think, sir?
Yeah, there are, of course, plenty of issues which we could have done better and must do better next time. I think 2 points are, for me, the most important. First of all, the coordination and the exchange of information could have been much better, and we should have more fact-based recommendations. In the last weeks, most of the member states, and in Germany, even the regions or the local districts, decided differently how to test, how to count, how to recommend to their citizens what to do and what not to do. And unfortunately, the virus doesn't care if it is in one part of Germany or the other part, or if it's in France or Belgium. So we should have more clear guidelines, what kind of analysis we have and what kind of consequences we recommend to our citizens. There are differences, but the differences didn't justify the completely different approaches. So I always said the same kind of recommendation for the same kind of situation. And the second point is, of course, that we need to be better prepared when it comes to the production of a vaccine. You know, we all were very angry, and I know that also inside industry, it was astonishing, and nobody really liked the intervention of Mr. Hudson from Sanofi, and he was completely wrong in what he exactly said. So you cannot give the vaccine to the US citizens and not give it to European citizens. There will be a strong answer from Europe, and I know that industry would not share Mr. Hudson's view. But one point is right, that the United States have been preparing for the production with their BARDA concept, and I think that is something we need to learn. And this morning, when we had the debate with Guido Rasi in the ENVI committee, the Committee for Environment and Health, I was a bit disappointed that many colleagues very much criticized the pharmaceutical industry, and they gave the impression that, you know, it should have all been done by the state. That is definitely not the solution. When we want to have innovation, we need to support those companies that come with the innovation, but we need public-private partnership, and those issues where there is no business case, there we need also investment from public bodies, and also industry needs to behave responsible. For example, this morning we heard also that the conditional licensing for remdesivir is in sight, and I'm very happy for that, and I hope that many patients will benefit. But Gilead needs to make sure that they have enough from the drug for everybody who is in need, or they should share with other companies that have the same kind of knowledge to really make it a business case. They should earn a hell of a lot of money, I think, but they should make it available for everybody in need.
Boy, there's a lot to chew on there, Peter. First thing I want to do, I'd like to go to Johan and sort of discuss the infrastructure side. How can we better be prepared? Do you have any reflection, Johan, on what Peter mentioned about the infrastructure? What, from your perspective, what should we have done better?
I think if you think about infrastructure, I think about the infrastructure of the workforce that we have now in cancer nursing. For example, it was great to hear from Han that a lot of new medication is coming our way for cancer treatments and for 40 different cancers he mentioned. It's great to hear we're working on vaccines. I saw also a question in the Q&A about prevention, and that's all great. But therefore, to do this and to deliver this to people affected by cancer, we need well qualified cancer nurses that's well educated to deliver this safely and to make it like quality cancer care for people. And so I think it's very important that if it's come to structure, we should invest in the working force infrastructure, for example, education, like I said, and access to all this equipment and new treatments.
Thank you, Johan. Kate, got a question here related to the OECD. The OECD has a model to simulate the need for scale-up after deconfinement. Is that model public and accessible? It's a question from the Ministry of Health in France.
Yes, thank you. So the OECD has a team that works on developing models to assess the impact of various diseases and conditions, and is pivoted to address COVID-19. Currently, a lot of the work is to assess the actual impact of different policies on reducing morbidity and mortality related to COVID-19. But I think we're seeing the needs of countries and also of other stakeholders shifting to start looking at how to model the impacts of the secondary effects. To this point, that's not something that we currently have under development, but we're starting to hear more, and it's something that we're considering proceeding with.
Thank you, Kate. Jan, I'd like to come to you somewhat with a reflection from what Peter Liese was saying. Is part of the problem the way we budget healthcare in Europe? It's really just a one-year cost as opposed to looking at more of an infrastructure. Do we need to really fundamentally maybe change the way we're looking at some of these expenditures?
I try to catch what you really mean. Of course, most health systems are planning their expenditures from year to year. But for hospital care, for instance, there are long-term hospital plannings being done on the regional or national level. And I don't see this is a big handicap for coming forward. I think we should of course invest in infrastructure, what is needed. Investing in research and development is a very special issue, and I think this is not the main issue where health insurers should participate in.
Thank you, Jan. And again, Han, I'd like to come to you with something that Peter had mentioned about some of the capacity constraints we have for production, particularly around the vaccine situation. Is there something we should be doing more in Europe specifically to try and get ahead of this? And potentially, could the solution we find for COVID-19 potentially be something for AMR, antimicrobial resistance? Do you see it? I'm sure you see it. You're smiling. There's obviously a connection there.
Well, I'm not sure there's a connection. I'm just smiling while we are trying to solve the COVID-19 disease. you jump to AMR as well, which is a very different animal. A couple of remarks up front. First of all, I'm very happy to hear how cool Peter Liese is under these conditions, because I can imagine how some of these smaller working groups within the European Parliament are looking upon things. I'd like to acknowledge that we have never ever seen in history, in the history of pharmaceuticals, so quick a reaction and so effective a reaction. I mean, let's be frank. If we talk about ourselves in Europe, probably second week, third week, fourth week of January, some started to take this disease seriously. And now we are in May, and we already have in the US a new compound that has been given marketing authorization, and we can be hopeful that it's going to happen soon in Europe as well. And in 3 months' time, we have now more than 120 institutions and pharma companies researching to find a vaccination against COVID-19. We've never ever seen that before. And understandably, the focus is now on production. But let's not forget, in our industry, there's not a guarantee that we come up with a compound that can be admitted by the authorities to patients in need of a specific treatment or vaccination. Having said this, if we see that it's so broad that now the research is taking place across pharma companies, but also in universities, we may be very hopeful. Then the thing with the production, and it has a lot to do with what we saw last week, we still don't know what to produce, right? I mean, the vaccination that can be effective can come from 3 very different categories. So many companies have already started at risk to scale up production facilities while still not really knowledgeable whether the treatment they're working on or the vaccination they're working on will actually come to market. I think this is really something to be left to private enterprise. If you take the old paradigm of 1 in 10,000 molecules being able to get to the market successfully, I wouldn't know how we want to spend public money on that with such a high risk of failure. That's just not doable for any government, I would say. In this very specific circumstance of COVID-19, I'm actually very pleased to see how intense the collaboration is between the academic institutions, how fast information, data are being shared across the globe. I mean, we are knowledgeable that there's been criticism on China in this respect, but China has revealed a genetic code of the virus very quickly as a basis for all researchers across the world to look into this genetic code and try to think of treatments and a vaccination that could be effective. We've also seen, it was mentioned by Peter Liese also, that Gilead, who's as fortunate to be able to come up with a solution for treatment now this quickly, has given licenses to 5 generic manufacturers in Pakistan and India, which is also unprecedented in terms of how fast treatment can be made available. But we don't have a magic wand. It does take time to come up with treatments, to come up with vaccinations, and also to come up with production. So one of the big learnings is, of course, how can we do better in a new pandemic with a new sort of virus we don't know yet. Let's not forget, things have moved this incredibly quickly because after MERS, several pharma companies and institutions have continued to research how to attack this virus, and that's also the basis one of the pieces of the basis where we are working on right now. In relation to production, we see a wide variety of companies that ask for help from governmental institutions or who are being offered help by governmental institutions. We also see companies do this really on their own risk. So I think here also the variety with which this problem is approached is probably the best way to remain as effective and efficient in relation to production.
Thank you, Han. I have
Tony,
another question. Yes, go ahead.
I think
Yes,
this
Peter.
is important. So first of all, it's true that industry is working much faster and cooperates much faster with EMA and others than any time before, and this has to be appreciated. But I think we need to be very precise, especially when it comes to remdesivir. So my first point is, you said it's a new compound. It is not exactly true because it existed already, and that is the reason why it can be made available so fast. So remdesivir was an existing compound designed for another indication, of course. The second point is, and here I think it's really important not to confuse things. My information from EMA and from Gilead themselves is that the authorization that they got in the United States is different. It's not as far-reaching as what they will get from EMA. So we are even better prepared with the European regulatory system for this situation than the US. That's at least what Gilead told me. And as a third point is, they are working with generic companies. That's true, and that has to be appreciated. But they want to keep it completely under their own control. And I'm not convinced that this will work out, because if they are the only company that manufactures the drug, even with a lot of partners, that's true. But maybe they can't scale up too fast enough. So that's why I think more cooperation with also not only generic companies, but also definitely innovators that have the whole value chain may be necessary over time. So I'm sure that this announcement from today will raise a lot of expectations, and it's important that pharmaceutical industry as a whole will be able to deliver the drug to whoever needs it, at least in the European Union, if not for the world. And there maybe even more cooperation is necessary. Thank you.
May I make a comment on that?
Yes, Han, quick comment, please.
So you're right, Peter Lies, of course. It's not an entirely new molecule. It has been researched and developed to work against Ebola, which was not effective. I mean, if we would think of creating a new molecule to treat COVID-19, we might see result in 5 to 8 or perhaps 10 years from now. So perhaps I was not clear enough. I meant to say it's a new compound for this disease. Unfortunately, we had one of those compounds. We will see more compounds, but then for the end stage of the disease, so where patients are really in the intensive care environment, with immunomodulators that are also on the market already. We are not talking about entirely new molecules, that's true, but that wouldn't have helped us anything at all for the next 12 months, because that's simply impossible for us. In relation to production, there's 2 remarks I would like to make. What we have recently heard quite many times also in Germany from our own Minister of Health, where he wants to get back production to Europe from Asia in particular. We are not very willing to believe that this is the best way to move forward. First of all, we should not forget that in the 80s, Europe, Germany were the biggest manufacturers worldwide. And for cost reasons, many parts of the production process has been, in fact, exported to Asia, where they could do this more cheaply than in Europe. That's not going to change. So it's really debatable whether we want to bring this back and pay more for something that could be developed in Asia or produced in Asia anyway, if we're talking about generic compounds. Because if we look at the patent protected compounds, by definition, these are being produced, also the active ingredients, in Europe and in the US. Now, there's one thing which is perhaps a bit out of sight if you talk about production. You can give any generic company in the world a license to produce, but at the current moment, we already have supply shortages. So let's not forget that the generic industry in particular is already struggling with the global demand. So it's not endless what we can dedicate to production of vaccines. If we talk about vaccines worldwide, it's 1.5 billion vaccinations we can produce. We might use or need 6 to 7 billion now. I mean, if you're talking about remdesivir in particular, new lines will have to be built up, or existing lines will have to be transferred to the production of remdesivir. That is not unlimited in terms of capacity. And again, we know, of course, that private enterprise is always the entity that is best able to come up with the most efficient conclusions, or the most efficient ways of producing.
Thank you, Han. If I could just also add, the studies that have been published are not the final studies. There's still other studies coming in remdesivir. The study that was published right now shows 4 days, 3 days better, shorter disease response. So the disease is 3 days shorter. It was not an outcomes trial. The prophylactic design prevention trial is still not published, and that's where we're really going to see the results. So there's still some time here. So right now we're talking, let's be very specific about the data that was published in the New England Journal of Medicine. We're talking about 3 days shorter of disease state. So is that what we want to be producing and fighting over for the entire world? That's an open question. I think, if there's a vaccine when we're needing 1 billion of prophylactic a year, that's a whole nother kettle of fish, and certainly another debate we'll need to have. And thank you both. That's an excellent discussion. I've got an interesting question here from Emma Woodford, which, Kate, I'm going to come back to you. How ready are we in healthcare systems for a second wave, if and when it comes? Catherine, what do you think?
Oh, well, I mean, that's a big question. I think that many health systems are already quite strained from the initial responses to the virus. But I think that one thing that we're seeing that's really good news is that there's been huge evolutions in terms of the data availability, data linkages between settings, the timeliness of data generated for use and governance of health systems, big regulatory changes in terms of access to telemedicine, for example, which has expanded rapidly in many countries. So I think that similar to some of the drug development that's happened quite rapidly, there have also been many other policies that have been able to be implemented quite quickly in response to the virus that previously had taken years and years to move forward. So I think that's the good news, but of course, there's more that's going to be needed to be done to address and improve the integration of healthcare systems. I think that one thing that the pandemic to date has highlighted is the vulnerability of some sectors like long-term care, and that's not going to be addressed, I think, overnight. I think that specifically for long-term care, the linkages with acute care will require more advanced governance. I think that we'll see that there are workforce issues in terms of having the appropriate staffing levels and competencies for people working in that care environment. So I think some things we won't be able to change in the short term, but some big policy progress has been made.
Thank you. Johan, quickly from your perspective, are you ready for a second wave in the nursing side?
what I can say, in our hospital in Ghent, I must acknowledge that management did a great job and to unfold a lot of services in a short time, and we learned a lot of it. I think communication is also key here, that we communicate and evaluated what's happening already. We have prepared a second wave plan, and hopefully we don't need to use it. But at this point, we can unfold, relocate healthcare professionals and healthcare use very easily. But hopefully, like I said, we hopefully don't have to use it in the future.
Fingers crossed, we hope. Got a question here from Lydia Meus, and this is regarding HTA. Evert-Jan, I know you're on the other side, but what is the status of the European HTA proposal, and how will Europe evaluate patient benefit of the COVID-19 treatment trials that are currently ongoing? Evert-Jan, I'll start with you. What is the current status of the HTA negotiations, and how will we be evaluating COVID-19 treatments?
The first part of the question is on the HTA file, and unfortunately, the German presidency gave some indications that they will not be able to find a solution in this year. So I'm afraid that this will take a longer time. That's very unfortunate, because the Parliament and the Commission were already there, and I think a compromise was not that far. But so that's the HTA file, and COVID-19 vaccines and therapies are now being assessed, of course, in a high speed procedure at EMA. And I think in EMA they are working 7 days a week on this issue. And if there is an effective therapy, we will not have much time for long HTA reviews. But the German EQUIC, for instance, made a letter to the EMA, to Guido Razi, yesterday or the day before yesterday, and they were asking to make the studies open, that everybody, also HTA institutes, have an overview, and that it's transparent on which basis the EMA took its decisions. We also got already from the EMA the fact that they say that it is very important that we are sure that these new products coming to the market are safe and are effective.
Thank you, Jan. Peter, Lisa, any comment on the current situation with the HTA interoperable plan?
Yeah, first of all, I would regret if Germany wouldn't be able to close HTA. I will talk to my Minister of Health, the German Minister, tomorrow, and we'll make that point, because I think it's necessary, first of all, to get more efficiency in our healthcare system, and to make it easier for real innovators to come to the market in all European countries to the benefit of the patient. So if it's true that we are under financial constraint after COVID-19, this is obvious. We need to be more targeted. I think we need to spend more money on health, not less. And in other areas, we need to save money, and also people that didn't pay tax, like Amazon, should start to pay taxes. That is part of the solution, I think. But we should be efficient in the healthcare system, and therefore HTA is an important tool. And I still think that the Parliament has struck the right balance, and so I hope we can make it. In the analysis of remdesivir, I think, first of all, please correct me if I'm wrong, Mr. Steutel or Mr. van Lente, in the German system, there is a two-step approach. When you have a licensing, an authorization from the EMA, you immediately get compensation from the healthcare system, but the price will be evaluated and the added value will be evaluated in the course of the months after the authorization. So you can ask any price. I hope Gilead will not ask a too high price, and then the price will be negotiated after some months. So it's a two-track approach, but I really appreciate that IQWiC would get the data already now, because cooperation between HTA bodies and the EMA is important. So I think we need to act fast, but at the same time, we need to be transparent, and all the data needs to be available also for those that analysis added value. And while we don't have the European HTA, we need to be pragmatic also in this regard.
And do you want to comment on that?
Yeah, so Peter Lies is correct. That's probably one of the biggest advantages the German healthcare system has with new innovative therapies, that they are available for patients after authorization on the next day, which means that they are also being reimbursed, because that tends to be the biggest hurdle. So that is a big advantage for the German population. Contrary to what you just said, Mr. Liese, pharma companies do go to authorities like the GBA and IQWiC for early consultations. So they have a consultation already prior to the marketing authorization to deal with the agency, to deal with their request and see what the company is being able to deliver in this respect. You do raise an important point in relation to existing molecules that are already on the market, where, of course, if there's a new indication then coming in terms of the repurposing, as Duane has already mentioned, an existing molecule can be used also to treat COVID-19, then, of course, we have to look into what this means for reimbursement in that specific case. But I'm pretty sure that under the given circumstances, a pragmatic solution will be found. I also want to point out that Gilead has stated a couple of times publicly already that it will come with a price that should make the therapy treatment option available to all who are in need. So that doesn't reveal what the price will be, but it does reveal the intention of the company.
Also, just for clarification, there was just an ICER published last week, if anyone wants to look it up, and the numbers are there. So there's been an evaluation. Ladies and gentlemen, it's been a fantastic webinar. We could probably go for another hour. We've got plenty of questions. Unfortunately, we are out of time. So what I would like to do is just ask a final question of our panelists, if they could keep it short to 10 or 15 seconds, just to be very brief here. And I'm going to go in the order that we introduced everybody. So final question for you folks, 10, 15 seconds. What one recommendation would you make to ensure the improvement of outcomes post-COVID-19? MEP Lisa, you get to go first, sir. What would you like to do?
We need to use the possibility that the EU treaty gives us. We can do much more cooperation in healthcare than we did in the past, and we should really do it now.
Thank you. Catherine, Kate, what would you recommend from the OECD perspective? What do we need to do?
Great, thank you. I'd say that there's a need to enhance regulatory frameworks and measurement for evaluating the competencies of healthcare systems as they upscale and downscale in response to the pandemic and after.
Thank you. Johan, from the nursing perspective, what do you think we need to do?
I think Europe should adopt EON's cancer nursing educational framework, because this will be beneficial in all layers of cancer care to deliver safe cancer care. And as of today, May 18th, is European Cancer Nursing Day, I just want to mention that EONS had just launched in the Cancer Nursing Index, which is a pan-European mapping exercise to identify where most actions are needed to address health inequalities in cancer nursing across Europe. So very important document, I think.
Thank you, Johan. Evert-Jan van Lent, sir, what do you recommend?
I recommend that we have work better together for a more targeted approach in cancer care, and that we have appropriate care in this sector. That's it.
Thank you. And Han, the final word to you, sir. What do you recommend?
Okay, thank you very much. Well, I'd like to bring a couple of things together, because I feel heartened by the remarks of Peter Liese and Evert-Jan van Lent on the necessity actually to have something like a Euro HTA. And I would really welcome this for the German presidency, in particular in relation to cancer outcomes. As the Minister of Health, Spahn, once said, science is not different in Madrid Riga, or in Berlin. So I think also in relation to COVID-19 and cancer, that would be a great step forward. For family reasons, I'm currently in the Netherlands. I buy the stuff at the supermarket and I'm not required to wear a mask. And when I do this in Germany, I'm required to wear a mask. So it's probably the best example I can give to you that I cannot see why we should not assess these scientific data on a European level. Thank you very much.
Thank you, Han. Thank you, all of the panelists, and I'd like to thank all of the audience for participation in this webinar. It's been a great conversation. We will be circulating the materials to all of you registered, including the PowerPoint and the video. I've had a couple questions about that. That will be coming back to you. And again, thank you for your time, and I call this webinar closed. Have a good afternoon.